Good day, all, and welcome to the Teledigm Pulse podcast, your rural health matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello and welcome to the Teledigm Pulse. Shane, we have an exciting guest today. Would you like to introduce our guest?
Oh, I'm ecstatic, Andy. We have a phenomenal guest with us today. I'm shocked at all these podcasts that we've done, even though this is in its infancy stages. Man, we've been blessed with some unbelievable podcast attendees and folks willing to share some time with us today. And today is no exception. I am delighted to introduce to you Dr. Allison Nazinitsky, who leads out our infectious disease consultation program. And without further ado, I'd love for you, Dr. Nazinitsky, to introduce yourself and tell our audience and constituents a little bit about yourself.
Yeah, so I'm Allison Nazinitsky. People call me Dr. Naz. I finished my medical school in 2010, and then I finished my infectious disease fellowship in 2015. I currently lead the infectious disease staffing solutions under Teledigm, and we have 11 infectious disease doctors working with us now. I physically live in Oklahoma, but I have 20 state licenses, and I've seen and worked in about, I would say, 50 different hospital systems, and it's been wonderful growing this program. So thank you for having me here on this podcast.
Oh, absolutely. We're just delighted you're willing to share some of your extremely valuable time with us today on our podcast and get to learn a little bit more about you and sort of what makes Dr. Nazinitsky tick. You know, Dr. John Horn actually introduced the two of us here a few years ago. And gosh, the rest been downhill, right, Dr. Nazinitsky? For you?
Only uphill. I know. I remember all of our calls together. It was just such a our first conversation, I thought to myself, wow, this is my dream team to be working with. And, it's been such a great time so far.
Yeah. Well, I got to tell you, I noticed that Andy over here, he orders this Monster energy drinks by the case, as you can see right there. And as it turns out, you two were comparing Monster energy drink cans here before the podcast started. So now I have some insight into what makes you tick, at least in terms of your high energy you always bring to the table, which incidentally, if you talk to a lot of the clients or the folks that know you out in, whether it's a hospital or hospital system, perhaps it was from a former locums job, perhaps it was from a telemedicine scenario, man, it's off the charts. Everybody loves Dr. Nazinitsky. Everybody loves Dr. Nazinitsky. You can't really compete with that. It's impressive. And maybe it's the Monster energy drinks is really stealing the deal. But I tell you what, let's talk a little bit about your journey into telehealth, telemedicine. You know, obviously we came along the way and provided you some different things as you got into this sort of line of work and business. But tell us a little bit about your journey, what led up to this, and what your experience has been going in so far.
So I think the U.S. healthcare system is fragmented, and a lot of times we lose track of the patients, which is really what I went into healthcare and infectious disease for. And so I had branched away from the traditional employed model in 2017, trying to find the right career path and the right program, the right team that also is in line with the ability to focus more on the quality of care, the capabilities of being able to provide care in the way that I wanted to. But so I really was trying to find a team that would allow me to work and focus on the quality of care. And so I branched out into locums work, where I was able to cover short-staffed infectious disease divisions and learn about different systems and be able to provide the high quality care that I wanted to provide. And then slowly got into telehealth, working with a couple startups. And then around 2020, I got introduced to MD Stewardship and was able to do tele-stewardship with MD Stewardship, and just realized the capabilities of telehealth is beyond anything that I had ever dreamed of, imagined, and saw this as my future way to be able to provide the care I desire and deserve, all the patients deserve to have. Being able to provide infectious disease coverage and expertise across the United States in places that otherwise wouldn't have infectious disease expertise.
Sure. Yeah. And again, back to the MD stewardship, it was a similar scenario. We actually met at a conference way back when, and we've been a great team in terms of moving that service out. They've been phenomenal. And incidentally, you should go back and check out that podcast. We covered the stewardship side of the equation here several podcast episodes ago.
Yep.
So feel free to go check that out. Maybe we can drop a link for that. But Dr. Nazinitsky, one of the things that I know you and I've talked about before, knowing the ins and outs of health systems and just the quality scenarios, what's predictive in terms of transfers and what's leading to transfers and poor outcomes, et cetera. And one of the things I think that you and I've talked about before is as it relates to the underappreciation of infectious disease involvement as part of a program, and how the virtual care really enables that level of expertise to the bedside. And whether it's the bedside or through vicariously through stewardship programs or other mechanisms, obviously covering the outpatient side, and to your point earlier, continuing to follow that patient even post-discharge. But the way that infectious disease it can be a game changer when you add this to the mix into a hospital across multiple metrics that can be impacted by an infectious disease professional. Can you maybe articulate a little bit around that in terms of your perspective as it relates to infectious disease in general and there's underappreciation of it?
Yeah. So there's not only an underappreciation, but there's such a shortage of infectious disease that I think healthcare systems tend to focus, on the surgical side or just the day in day out patient care. But when you get a complicated case that requires expertise for antibiotics or diagnostics, being able to provide that level of care locally instead of transferring, or at least mitigating some of the questions locally before transferring, I think it provides a lot of benefit to the local hospital. And then also the patients have a higher level of respect for their local hospital. So not just for infectious disease, but for all specialties when we're able to keep them local and provide the care locally. But the underappreciation, I think we tend to get, it's not a priority initially on hospitals to focus on infectious disease until it's almost like a crisis situation arises, or say a surgeon has an affected knee, for example, and that patient now has to be transferred for an infectious disease consult. Then this crisis kind of arises where someone locally may want to keep the patient, but they're not able to because they can't provide that expertise. And I think TeleID, I think we really show our value when it comes to these almost like crisis situations. And then once we prove our value in that respect, it's like, oh, well, we need you for so many other things. And then all of a sudden, it's 10 different issues that have arisen out of that one consult or that one question. And then it seems like there's so much more opportunity to grow the hospital.
I think this is a combination of a couple of things here. Number one, as you talk with surgeons or hospitalists or primary care physicians or whomever it is that are taking care of patients in hospitals in the outpatient corridor, it's been so long. They're so used to not having infectious disease even available to them that they really don't know any different, right? I mean, they don't know.
They don't know what they don't know.
You're right. And so how do you really fully understand what an infectious disease physician can really do if they get in the mix? And I'll give you an example of and some of this isn't well articulated by the local medical staff. For example, a surgeon who said, I'm not doing surgeries at hospital X because they don't have infectious disease physicians available in these particular scenarios where I really want them to have ID. Well, they don't go to the hospital and say, hey, just so you know, I would do these X cases if you had ID. They don't do that. No. They're moving on to the next patient. They're not going to go try and spin this in a way to bring this to fruition, right? So it's to your point, this bolsters confidence in the surgeon in the surgery corridor, both orthopedics, general surgery, among others, of course. And it really improves the confidence level in those folks doing surgeries at different hospitals. And the penetration that you can get with infectious disease across the board through virtual strategies, really, it opens the doors for so many different things. And so I can't agree with you more. And the quality components are huge in this. And to your point earlier, Dr. Nazinitsky, we do run into that a lot, where we'll get a call from hospitals saying, "Oh my gosh, our C. diff is X, or our readmissions are X, or our vancomycin therapy days are at X," and we're having this huge infection issue coming out of surgery. We've done all this infection control work and nothing's working. Well, odds are good that through an infectious disease strategy, a lot of that stuff can be mitigated. We've seen countless examples that in situations like that we've been able to help. But I can't emphasize enough, having infectious disease involved early on in the process and available for the process to be part of that collaborative team is such a huge, huge advantage. Man, it's amazing. Let's talk a little bit about your personal job satisfaction and work-life balance as it relates to leveraging sort of the virtual side of the equation compared to the day-to-day, the day-to-day grind of the normal in and out of the hospitals. And then, to your point, the ability to help so many more patients in so many more different locations by leveraging these virtual technologies. Can you kind of give us some insight on how you feel about that? I know you did a little bit of telehealth prior to coming to work with us and building out this team with us, but can you give maybe some examples of your experiences around that and where you're at from a job satisfaction perspective?
Yeah, so I think satisfaction in my career as a physician and in infectious disease really stems a lot like my autonomy, being respected, being appreciated, and having the collegiality, just good collegial interactions with nursing staff and other specialists, and then also being able to spend the time that I want and need with the patients and not feeling rushed. And so that's really where my job satisfaction comes from, is those basic points. And through telehealth and through working with all of the hospitals that we work with, it really allows me to have that, like the perfect mix of all of these values that I've wanted. So, as far as the collegiality, some of the smaller hospitals have some of the most incredible primary care doctors that are very involved with their patients. Some of them have known patients for 20 years, and so my job satisfaction, being able to provide the expertise to that local level, and not only help the patient but also help this doctor who's cared for this patient for so long. It's unexplainable how great it feels, and it really leads to a lot of job satisfaction. And I think through the almost like this culture shift of when telehealth is brought into some of these hospitals, and I may have been one of the first specialties on board. It's almost like the culture shifts, and it's the nurses are very involved with bringing us into the room, and the nurses want to stay in the room. They want to listen to what we have to say. The referring physicians also are very interested in what do we think and what should we do. And it's beyond anything I've really experienced even in person. Even though I'm not physically there, I still feel entrenched in the systems, and having that collegiality has just been a game changer for my job satisfaction. Being able to then get some of my colleagues that we also have that same goal of providing high level quality patient care, where we have autonomy, where we are respected and we are appreciated. I've been able to grow this program. Now we have 11 total doctors, and hopefully continue growing. And these are doctors, some of which I've known even through fellowship in 2015, 2017. And we all work very well together. And we may not work physically together, but we've worked together since even fellowship, running cases by each other. And so the doctors on our team are really high quality and have the same goal in mind of providing that high level of care locally and keeping the patients local if needed, or if we have to transfer them. So it's been, I think from that perspective, it's just been a dream to be able to be part of this.
That's great. You mentioned your colleagues, and I can't emphasize enough. It's interesting. We've seen this, Andy, right? I mean, it's why it's so imperative that the folks that are leading out these programs, particularly the physician side of the equation, and who you ultimately recruit and bring to the table to then provide this service to the clients and the patients across all of our hospital entities, which there's a lot of them in a lot of different states. But the consistency is so important.
It is.
Collegiality is so important.
Yep.
And the FaceTime is so important. I say FaceTime, beds, I don't know, bedside manner, screen side manner, FaceTime manner, whatever kind of manner you want to talk about, something, some sort of manner. But at the end of the day, they're all high quality providers, which is great, but the interactions that they have with the nursing staff is significant in terms of that relationship. And it's always so solid. And the relationship with the patients is always so solid. The documentation is just spectacular
Yep.
across the board. And those types of talents and skills attract, they're like magnets, right? They attract each other because you're going to be around, right? I mean, you're going to see individuals or no individuals. I mean, you're going to get a call from Dr. X, who you know well, and says, "Hey, Dr. Nazinitsky, I'd love to join your team." And you're like, "Yeah, I don't think so." I mean, come on. You do not quit your day job. Okay, we're going to do something different. But the bottom line is, right? Going into this, in most cases, who's going to be a value add to your program and ultimately the build of this program and what's going to lead to success.
Well, and time again, we get feedback from nurses and patients, they're not sure about what this telemedicine encounter is even going to be like. And yet when it's done, they're like, this was incredible. I felt cared for, I felt heard, I felt seen. In the presence that you give on the screen and your colleagues give on the screen really brings that caring across, and the patients can see.
Yeah, for certain. No, I mean, no doubt about it. And, infectious disease, shifting gears here just a little bit, definitely transcends, multiple departments across an organization, unlike some of the other specialties, which is sort of walled off in certain areas. Pulmonary critical care, granted, pulmonary can kind of transcend multiple areas, but ID in particular really does sort of morph and gravitate to all kinds of different sectors within an organization. It's got implications in the ICU, medical surgical units. It's got implications in the ED. It's got implications outpatient pharmacy, and the list goes on. And then wound care. And so, Dr. Nazinitsky, could you maybe describe kind of how, from your perspective, how infectious disease kind of transcends multiple departments within an organization?
Yeah, so we really interact with everyone. We interact, with radiology, interventional radiology, hospitalists, OBGYN, all the surgeons, outpatient, even through like home health agencies, outpatient antibiotic agencies. We're really involved with a lot and a lot of downstream implications. So I always like to discuss the reducing readmissions and toxicities and being able to help provide this quality of care, not only in the hospital but out of the hospital. And I think through the relationships with Teledigm, my hope is that we can follow patients in swing beds, we can follow patients in the skilled nursing facilities, follow them at home, and really be able to provide that full closed loop care where we're communicating with primary care doctors after discharge. We're able to communicate with all of the home health agencies and everything like that, so that we're able to provide this continuum of care. We interact with the pharmacist, like you said, the pharmacist, especially lab, micro lab, all the send outs that we order and follow up on. So it's really, really, we interact with everyone.
Sure. And you bring up a great point. It's similar to the discussion a little earlier where golly, you only know what you know.
Mhm.
And the thought of actually having an infectious disease physician available from a transitional care perspective as part of that closed loop mechanism, as part of that continuum, is really it's an amazing proposition. I think, we have some interest in that, but there again, I think you sort of, you get into a scenario where people go, really? I mean, I could have that. I mean,
Mhm.
wow, that'd be amazing if I had an ID physician that could weigh in on this septic joint that was going to be discharged, and there's going to be on antibiotics for X amount of time, or this, regardless of what the situation is, but multiple examples. How about, Dr. Nazinitsky, some examples? Give us, I mean, you have so many wins over the last several, months, couple of years, in terms of scenarios that you've been involved in from a consultative perspective that then leads to, perhaps they were considering transfer prior to the engagement and mitigated a transfer. Perhaps you picked up something that was interesting. I know that you and I have talked about a couple of those examples. Can you maybe share a couple of real time, sort of, well, not real time, I guess this would be recorded time, if you will, or retrospectively, a couple of ID scenarios?
Yeah, I think it's always dependent on, yeah, what call we're getting. But I think the biggest bread and butter win for keeping patients local is like a diabetic foot infection or osteomyelitis. Oftentimes, it's just sometimes it just takes a little bit of reassurance for the primary doctor or the hospitalist, but sometimes they may feel like that it's out of their wheelhouse for like a resistant organism, MRSA or ESBL infections, and so um, when we get called from a hospital that they have podiatry, they have good wound care, but then they want that extra level of consult, the consult for osteomyelitis. We can keep the patient local and give recommendations in the chart real time and coordinate with the case managers and all the team that's locally to prevent the transfer for that case. Sometimes it's just a matter of reassurance where, say, a patient's used to work going to a big tertiary care center and instead is now at the local, critical access hospital, and everyone's saying, "Oh, this is okay. This is okay. Well, how about let's have our infectious disease doctor come on board and look at your chart and consult with you and make sure that we're not missing anything." And sometimes it's just a level of reassurance to the patients, but then that provides their team that comfort level, and the patient the comfort level that they are being seen by a specialist, that they would be seen at the tertiary care center. So I cover all over. So it would be me possibly that was seeing them at the larger center, but instead I'm able to see them at their local center. And if they need to have coordination for follow-ups, whether it's in person or as an outpatient, we can help coordinate that as well, because we work with all of the doctors, in a lot of the states. So, or at least in Nebraska, where we can help coordinate a lot of the follow-ups and make sure that that communication is strong between everyone.
Yeah, absolutely. Can't agree more. And I think to your point, it does boost confidence, not only with the providers, but certainly the patient. We run into that in several scenarios of patients that are, or families that are reassured by having the specialist available to come on screen. And sometimes, from your experience, you spend just as much time, if not more, with the family than you do the patient sometimes, in terms of those discussions. But certainly, it's so helpful for you to say, listen, you know, gosh, if you're going to be sent to Hospital X, I'm probably going to be the one seeing you there virtually too. And guess what? We're going to be doing the same thing there as we're going to be doing where you're at right now. How about we just stay there? At least that's
Mhm.
a pretty solid recommendation coming from you, I would think. And certainly with your reputation and the patient experience and engagement scores they have with you, as well as all the staff there, Dr. Nazinitsky says, "Gosh, you're doing great. You're going to stay there. I'm going to help take care of you." I mean, who's not signing up for that, right? I mean, I
Right.
think everybody's signed up for that. So it's a huge value add, certainly. How about another couple of examples. You mentioned osteomyelitis. How about, I know you and I talked about a breast abscess scenario that you came across and as part of a consultation. How about that?
Yeah, that was another sort of reassurance. The primary doctor had been doing everything that I would have done, and the patient felt like they weren't getting better quick enough. And so it was more of like a second opinion and make sure that everything looked okay. And a lot of the hospitals we cover have excellent nurses that take photos of wounds, and it's all HIPAA compliant in the EMR, but they're really good about taking photos. Like on admission, there's a photo. The next day, there's a photo, and sometimes it's the doctors that are also adding it. But it's really this culture of putting the photos in the chart because there's tele ID, and it's really helpful because you can go back and even have the nurse pull up the photos for the patient to say, well, hey, it looks like this actually is getting better. And so sometimes with that case in particular, I think they were just worried it wasn't getting better quick enough, but it just wasn't going to get better in a day. It was going to take a couple weeks for it to get better. And so giving that reassurance and coordinating with the primary to give that reassurance, I think was helpful, and the patient ended up feeling much more comfortable with that plan.
So again, back to reassurance, right? And reassuring the provider, because we do run into that a lot. Even if you go way back on the tertiary center analysis and incoming transfer data of patients that were transferred for ID consultation, the percentage was exceedingly high of, if they had virtual ID available, would not have had to have been transferred. Right? And some would argue they wouldn't have had to been transferred anyway, but based on the numbers, it's significant. And so you run into those scenarios where, if I'm the doctor taking care of you, Andy, and you've been in the hospital for a couple of days and you're not feeling any better, it's not getting any better, your perception is it's not getting any better, and then you say,
Mhm.
well, Dr. Shane doesn't know what the heck he's doing here, we're gonna have to, we got to bolt, we got to go somewhere else that knows what they're doing so I can get to feeling better. And man, it's a huge help to then bring an expert like Dr. Nazinitsky to the table in that scenario and say, how about you check this out just to make sure that everything I'm doing seems to be in line with what you
Mhm.
think would be appropriate. And by all means, if you come up with a different strategy, man, let me know. And then, hey, go ahead and evaluate the patient, do your consultation, do your consultation note, chat with the family, and collectively they become way more comfortable in those scenarios just by having you available there. So, gosh, can't agree more on any of that. How about any other situations, that you've been involved in from maybe some of our larger facilities? Obviously, you have some ICU level patients. Can you give some examples of some ICU types of scenarios that you've come across for maybe some of our larger hospital listeners?
I think, well, one of the diagnoses, and I mentioned this on the cases that I did, is meningitis. I think meningitis is a diagnosis. So if true bacterial meningitis or HSV encephalitis, patients can be very, very sick, and having ID expertise is very important, especially like elevated intracranial pressure and just knowing, being part of that initial diagnosis. But sometimes it's just an aseptic meningitis where, yes, there's inflammation in the spinal fluid, but may not necessarily need specific treatment, just supportive care. And I think that's one that transcends not only keeping patients local, but also at the larger center being able to be involved with, up front, and being involved at the tertiary care level because they're quite sick. Um, and we work very closely with the intensivists if they're on the ventilator, and also neurology for those cases. And so working with teleneuro at the smaller hospitals is also, um, has been, really awesome because we can keep the patients local, and it's almost like a pod where we're bringing this tertiary level care to a smaller hospital, but then also following at the larger hospitals, if they have neuro in person or overnight, um, teleneuro. But I think meningitis is a good diagnosis where, we have a lot of expertise with treatment, and also just a lot of uncomfort and unsettledness around meningitis in general, what to do even with precautions, isolation precautions, and say the cultures remain negative and all the testing is negative, what do you do next? Those sorts of things. So I think meningitis is another diagnosis that comes up quite frequently for telehealth infectious disease that we make a pretty big impact.
Sure. How about sepsis? Do you maybe speak a little bit to sepsis and early sepsis? Because for example, some of the things we run into with a lot of the facilities is, well, they may become X or they may become septic to the point of shock, borderline shock types of things. And I think it's so helpful to have expertise available in those types of consultations and involving infectious disease or pulmonary critical care, both, where you're involved in those scenarios to help mitigate and help guide the course of action in those. Can you speak to that a little bit?
Yeah, so there's been a lot of studies that show improved outcome with Staph aureus bacteremias if you involve an infectious disease doctor, and then also for gram-negative bacteremias. So as far as sepsis is concerned, yes, I think getting us involved early is important. Whenever there's not a clear source of sepsis, also getting us involved early just to make sure we're identifying the source, because source control is really the most important part of any infection. I mean, antibiotics are important too, but source control is really important.
That source, it's just lots of things I look for the source. It's just having trouble finding
Yes,
that sometimes. Yeah, it's great to have you
yes,
as
yes.
part of
So
that.
finding the source. And I think sometimes it's like, I'll be on the phone and it's like a 2-minute conversation and I'm like they're like sepsis, sepsis, sepsis. And I'm like, okay, sepsis from what? And it's like, oh well, we don't know. And so and I think that's really the most important thing to focus on is, well, where is this coming from? Are they truly septic? Like, is this an infectious mediated sepsis syndrome, or could this be autoimmune or inflammatory and other ways. So just being able to weigh in early and then, say on hospital day 2, all the cultures are negative and may not necessarily be sepsis, like gout. Gout can cause all the same similar symptoms as sepsis, hot red knee or whatnot. And everyone's worried, but what sometimes I'll get called and I'll just say, well, no one's asked, like, have you had gout before? It's like, oh yes, I get gout all the time. And, have you had it in your knee? Oh yes, I've had it in my knee. And so, and it can look just like,
In fact, this feels a
yes,
lot like
yes. So,
that.
and sometimes you might have gout and a septic knee, which also would require an ID doctor, but sometimes it's just, little things may get overlooked. And I've seen that a couple of times, even recently, in person in a hospital system where it's like, it's just, it's gout. It's a really bad gout flare that looks like infection, but say all the cultures are negative hospital day 2, then, peeling back the antibiotics, I think is another part where we have a really big impact on not only drug toxicities, but C. diff and things like that by stopping the antibiotics.
Boy, I can't agree more. We've seen that time and time again, and certainly having an infectious disease physician involved in those cases early, to your point, early is great versus the point of, gosh, now we're hemodynamically unstable and things are going south and we don't know what's going on with them. So can agree with you more on that front. Well, listen, Allison, is there anything else that you would like to add as part of this discussion today?
Part of this conversation, I just really wanted to bring awareness to the ability and the feasibility of bringing infectious disease to any hospital system across the country. This doesn't have to be every single day. We don't need to see the patient. We can just be available for one consult a month or one consult a year. And I think a lot of hospital systems don't realize that that's actually a capability of teleinfectious disease, having us on board just for that one instant of an emergency situation, and we're available and we're willing to help in any way possible. And I think the best part about working with Teledigm is this custom created model of care where what the hospital needs is what the hospital gets. And I think that's the most beautiful and most the best part about this is just being able to provide fulfill the needs that these hospitals have in order to provide the best patient care, because it really is all about the patients at the end of the day. And even if it's just one consult a year, it's still worth reaching out and getting us involved and having us on your team in any way and in any capability.
Well, perfect. Perfect. Well, I really appreciate you adding that nice little tidbit there, and can't agree more that having infectious disease available is a huge value add to any organization, regardless of the size. And obviously, you can go back to any of our other episodes. We've covered physician staffing strategies, which that's in an upcoming episode as well, and how these types of programs can impact that. But certainly, having an ID on board is really mission critical and can provide a significant value to your organization. So, Dr. Nazinitsky, from the bottom of my heart, thank you so much for spending as much time with us today as I got to tell you, she's put up with us for over 45 minutes now, or coming up
About
on
that,
it, right?
yeah.
I'm probably going to get a bill. I'm thinking. I think I'm probably, yeah. I think we're going to get a bill. But I really do appreciate taking the time. That I know you're busy as all get out, and beyond that, I truly appreciate our relationship with you, Dr. Nazinitsky, and our patients, on behalf of our patients and all of our clients that have been blessed with having you as part of their program and organization and taking care of their patients. They unequivocally across the board would thank you from the bottom of their hearts as well. So can't thank you enough for participating with us today.
Thank you so much for having me.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@TeledigmHealth.com. For more information or general inquiries, please visit teledimhealth.com.